Thank you very much. Again, it's quite a pleasure to be here. I wanted to explain some things that I have learned through 3 representative cases that you will see at the end all have somewhat of a common theme. The first one is a case where I made a very stupid mistake and learned a lot from it. 7-year-old girl with visual loss in each eye, kind of nonspecific, and everything was fine when she was playing with her friends, but she didn't do well at school. And of course, she'd seen many doctors already. And you can see this is a sort of puzzling visual acuity that we get, 2100 and 2200 at distance, better at near, but she improves with pinhole, and with just minimal refraction improves even more. So it doesn't add up mathematically. She had no significant refraction. The pupils were normal. She had a little dyschromatopsia, but then again, she missed the color plates. The fundus looked normal, and she came in with a neuroimaging elsewhere that was unremarkable. So I did a visual field, which shows moderate parameters. Some people look at the gray scale here and they say, oh gosh, I think she might have a little quadrantinopia. That's always an error to do that. If you look at the pattern deviation, you see it certainly crosses the midline, and this is more, if anything, of a central defect. So what is the next best thing to do for her? Do we image again, get a visual evoked response, or is this just not adding up and it's non-physiologic or functional disease? And that was the diagnosis that I made at that point, and had a long discussion with her mother about things like stress or anxiety in her life that could produce this. Now, of course, 2 years later, she went to see another doctor. Her visual acuity was 20/70. Her color vision was worse. And if you look at the fundus now, you do begin to see some fine pigmentary changes in the macula. And fluorescein angiography showed dark choroid inconsistent changes with Stargardt syndrome. So what I learned from this is that macular dystrophies are very common in the first 2 decades of life, and Stargardt is more common than all of the others put together. The visual acuity may decline a long time before you see a change in the fundus, and we have a lot of ways to make this. It's not just fluorescein angiography, autofluorescence, or a multifocal ERG can help as well, but usually the full field ERG is normal early. Of course, now we can do genetic testing. But it also brings this concept to the forefront of functional overlay, and where patients have a true organic cause for visual loss, but the vision that they report is actually not as good as what it is because of anxiety or stress associated with that. And so here's just an example of how autofluorescence is helpful. Now, second case, it was a 16-year-old girl who was on a graduation trip with her family to Hawaii, and there was a lot of family conflict during this vacation, and she had a large argument with her parents and became very stressed and immediately stated that she had a sudden loss of vision in her left eye. She was seen in Honolulu with vision acuity of 20/20 and count fingers. Pupils were documented as being normal. A field wasn't done, and the fundus exam was felt to be normal. So this is a very good ophthalmologist whom I know in Honolulu said that I think this could be retrobulbar optic neuritis, but on the other hand, the pupils are normal, so this may be a functional non-physiologic complaint. She was treated with intravenous steroids, had neuroimaging, which was unremarkable, a low positive ANA, and she improved from count fingers to 2200. She returned home, and the following week, her other eye began to develop symptoms. And she had acuities of 2400 and 2250, but note there was a significant improvement with a pinhole. Pupils were reactive, clearly not an RAPD, and the fundus was documented as normal. So this is one eye showing a large central scotoma breaking out superiorly. On Goldman perimetry, you again see a large bilateral central scotoma, but the peripheral field is very, very full in each eye. So we looked at the MRI, it was clearly unremarkable. A lumbar puncture was normal. Lyme titers were unremarkable. So the ANA was repeated by this doctor, and it was now positive at 1 to 360. However, the anti-double-stranded DNA antibodies were negative. She had syphilis serology that was negative. And so now the diagnosis has moved to possible retrobulbar optic neuropathy due to lupus, but again, the possibility of a functional overlay in this girl because of the mismatch between, for instance, acuity with and without a pinhole and distance and near. So based on the repeat ANA that was more positive, she had another course of IV Solumedrol and a rheumatology consult who found a totally normal exam and history. They repeated the ANA a third time, and this time it was completely negative. And the patient states that her vision continues to get worse in both eyes. So this is the time where I saw her. She was 4/200 and 20/600. Pupils definitely had no RAPD, but no colored plates at all. And now this is the fundus exam you see here, and this is about 6 weeks later. You can see that there clearly is some temporal pallor of the optic disc, and you can see the very straight demarcation line of the neurofibrillary atrophy and the papillomacular bundle in this eye, and a very similar picture in the fellow eye as well. So although there may be some functional overlay, functional disease is not the sole answer here. She had an ERG, which did not show any evidence of retinal dysfunction, and the VEP couldn't be performed because the patient was really unable to fixate on the target, so it was not reliable. So what do we think about now? Do we need to look at the visual pathways again via MRI given the progression of disease? Could this be neuromyelitis optica, DeVick syndrome? Do we need to look again and look at the spine carefully? And do we need to do aquaporin 4 titers? Or is this business with the fluctuating ANA evidence of some sort of undetected autoimmune disease or vasculitis? What should we do at this point? Well, I decided that the most efficient thing to do would be to get genetic testing for Leber's optic neuropathy, and she was indeed positive for the 14484 mutation, which is fortunately one of the mutations that does allow spontaneous improvement, and 3 years later the right eye improved to 20/20. This is 3 years later, and you can see that although she has a dense paracentral scotoma, if you look at the foveal threshold, it's 34, and so there's a very small window of good acuity right through the middle of that field defect, which is the pattern of improvement that they get. The other eye still hasn't improved, but she's hopeful that that will occur later on. Foveal threshold 15 there. So some things that we can learn from here is that Leber's hereditary optic neuropathy certainly does occur in females. It's not that common, but it's well documented. And of females that have the mutation, 10% will actually get phenotypic expression. Interestingly, whether we don't think about it typically, some of these actually occur in the first decade of life. And this is a particular disease that we must remember that even when symptoms are unilateral, that an RAPD may not be present. This could be because of preferential sparing of pupillary fibers in this disease that affect the motor function of the pupil without the vision, or it could be because of subclinical mitochondrial dysfunction in the fellow eye. We don't know for sure, but it is well known that early on, an RAPD can be absent in unilateral symptoms in Leber's. One of my mentors from Bascom Palmer, Lawton Smith, had a favorite phrase he used to say, which is an ANA is the world's most useless test. And he meant that it's very nonspecific and it can be quite variable. And of course, if it's 1 to 2048, then it's important. But if you're suspicious of active lupus, an anti-double-stranded DNA titer is a much more specific test for that. Fortunately, some of the 5 common mutations do have spontaneous recovery. But again, we see this theme of organic disease with functional overlay here, as we did in the first case. So often patients have an emotional component to their disease as well. Let's take a look at this one. The 17-year-old football player, American football player, so was wearing a helmet, and he had a helmet-to-helmet impact with another player on the right forehead, and then his helmet somehow fell off, and he got hit again on the right forehead, and immediately stated that the vision decreased in the right eye. So he was seen by a local optometrist that found an abnormal visual field, referred to the hospital. He had a CT scan of the head, which was unremarkable, and admitted for observation for concussion to the neurology service. Now, the interesting thing was that the prior year, he had a back injury while playing football, and he had a right hemiparesis, arm and leg, totally hemiplegic, for 24 hours, and it spontaneously resolved. They found no etiology for that. So at the bedside exam, he had good acuity, normal pupils, normal external exam, but you see his confrontation field showed a very dense temporal defect only in the right eye. Dilated fundus exam and intersegment was normal. So what do we do now? Do we look at the neuroimaging again with an MRI? Does he need lumbar puncture or VEP, or really do we need to see what the other what the field is like? And I chose the field because I'm really interested to know if the normal eye has a subtle field defect that could be chiasmal. And you see here, though, on the left eye, the field's really, for the most part, unremarkable. On the right eye, there is a dense temporal defect, but if you look at the pattern deviation, it crosses the midline. So all of these things have been reported in the literature to cause a temporal hemianopia in one eye. Of course, we know there's not optic nerve hypoplasia. We don't see any optic atrophy here. We have a neuroimaging that, at least a scanning CT, that doesn't show anything abnormal. So we're very suspicious for real functional or non-physiologic field loss here. And so I thought there's one way we can prove this, and that was a binocular visual field. So I did a field with both eyes open, and unfortunately for me, it turned out totally normal. I was hoping to see a right-sided visual field defect with both eyes open to prove the diagnosis of functional visual loss, but it didn't work. So we move on to the next step, Goldmann perimetry. And here you see in the affected eye, there's crossing of an isopter or spiraling here, which is physiologically impossible. If you think of the visual field as a hill of vision, you're cutting across this way, it doesn't move up and down like that. You can't have a spiral field like that. And here's on the Goldmann, the binocular visual field. And you can see this was a proof of non-physiologic visual loss, because on his right side, he only has 30 degrees of visual field. And we know from the fellow eye that it goes out to 55 on the nasal field of the left eye. So this is proof of non-physiologic visual loss. Of course, the neurologist wanted to get a scan anyway, which was normal. So we had a long discussion with him, had him come back in a month. He said, everything is fine now, my visual fields returned to normal, and again, here he is with no intervention, totally normal visual fields. So there is another story to hear. This is a boy who's smaller than I am, and his father has been pushing him to play football, but he wants to go to art school and become an artist. And so this was his mechanism to get out of playing football. And in fact, the hemiparesis from the year before was non-physiologic in nature as well. Again, an attempt to get out of playing football. So there's often a large family dynamic that comes into this. And fortunately, I was in a position to have this family begin to address some of the conflicts. And it turned out very well, and he actually went to a very prominent art school in Georgia and is employed as an artist today. So some things to learn from this case is most of the time we think of functional or non-physiologic visual field loss as affecting just visual acuity, but in fact 20% of cases have both the field and the acuity affected. And although functional visual loss may be seen only 1 or 2% of the time in a general ophthalmology clinic, in neuro-ophthalmology it accounts for 12% of our patients. Remember the visual fields in functional visual loss. A confrontation field will tunnel without expansion. I showed you a Goldmann perimetry that spirals or where the isopters cross, and sometimes the Humphrey is just black and uninterpretable. And remember the usefulness of a binocular visual field, whether it's Humphrey or Goldmann, and sometimes if one doesn't work, you may need to do the other to make the case. So I'll just close by talking a little bit about a large series we reported of functional visual loss, 140 cases, so it was a very good sample. It occurs in all decades of life, but the biggest decade is the second decade of life. 38% of cases were there. Psychiatric history was definitely higher in adults than children, but in a large proportion of patients there was some sort of social or emotional event that occurred. For adults it was often physical or trauma or surgical trauma. For children it's relationship problems in the family, relationship problems with other children at school, or difficulty in school as well. Migraines were relatively common, but I want to address your attention to the bottom of this slide. There were 3 out of the 140 cases that were misdiagnosed as functional when there wasn't an underlying disease. And I showed you my case of Stargardt disease. The other one was cone dystrophy, and one was another Leber's. Importantly, one child was the victim of physical and sexual abuse, and the way that was diagnosed was through the functional visual field loss. This is a meta-analysis of everything in the literature. Most of them are female. half of them have some underlying trigger defect, a third of them have psychiatric issues, and you can see the 2% misdiagnosis rate, the common things being, again, macular dystrophy, hereditary optic neuropathy, and small bilateral occipital infarcts. So I hope this will be helpful to you in your interactions with similar patients. Thank you for your very kind attention.